Hi, everyone. Welcome to the Initiating Out-of-Pocket Cost Conversations webinar. Just going to give a few more minutes for some people to join, and we'll get started shortly. Alrighty, I am going to get started. You might hear some people hopping on. That's okay. We'll go ahead and get started. I know everybody is on their lunch, and I'm so happy that you came and joined us for this webinar, Initiating Out-of-Pocket Cost Conversations with Patients, Lessons from the Field. My name's Amanda Allen. I'm the coordinator for the Cost of Care Conversations project here at NYACP. And today I am so happy to be joined by some of our participants in the Early Adopter Incentive Program. They're here for a roundtable and Q&A after a brief overview of the project. We have Dr. Susan Lee, Associate Professor and Practicing Physician at Stony Brook Internal Medicine, Dr. Jeremiah Benoit, a practicing physician in Amsterdam, New York, Dr. Donna Seminara, a practicing physician in Staten Island, and Karen Tusing, who is the practice manager for Dr. Gordon Tusing in Buffalo. Before we begin, I just want to review a couple of guidelines. As is normal, all participants will be on mute. And if you have a question that wasn't submitted with your registration, please go ahead and type it in the dialog box to the right. We'll get to it after the brief presentation that I have. And then we'll go ahead and do the roundtable. If we run over our allotted time, so we want to end at 1 o'clock and keep everybody on time, and there are unanswered questions, I will be sure to send those questions through the answers through email. And then we will have the slides and the recorded version of today's webinar posted shortly on our website under the Patient Empowerment Resources page. I have a link here if you want to copy it, but you can find it on nyacp.org under the Practice Management heading. And really, what I just want to open up with is an overview of the project. And by the end of this webinar, I just want you to be able to compare some stories from practicing physicians so you know what others have done. I know that's really helpful for you to add things to your own workflow, and you'll get ideas, tips, materials, and resources from what we've learned from the whole project, as well as those physicians and staff on the call today. So just a quick project recap. We, in 2018, 13 practices from across New York State signed up to become part of this early adopter incentive program. It was funded by the New York State Health Foundation, a private foundation, and they implemented out-of-pocket cost conversations with patients. And for 12 months, they gave feedback, both qualitative and quantitative information. We had a range of offices. We had solo practitioners, we had large groups, and anywhere in between. We also had independent and hospital-owned practices. So there was a wide range represented, and they were also, as you can see, spread across the state in both rural and urban areas. So we had a pretty good representation of the state. For the actual cost of care conversation, I just want to clarify the definition. So we started with this basic definition, but it's most important to know that it's not about system costs, it's about out-of-pocket costs. And you might even be having these today. We found out a lot of conversations fit into this definition. So it's really whenever you're bringing up information pertaining to what a patient might pay out of pocket. It might be for that exact visit, it might be for something in their treatment plan, it might even be having to do with going to their specialist or the amount of visits they have. So we have direct costs, copays, deductibles, and indirect costs. So transportation or missing work or childcare. So any of these things that you talk about them really with your patients really do qualify as a cost conversation. So it could be anywhere from talking to them about planning for the possibility of hitting the Medicare donut hole to consolidating visits so that they don't have to miss so much work. And you don't have to give an exact cost. Sometimes you can give ranges or an idea, or just remind them that something is going towards their deductible. So that's what we mean when we're talking about cost of care in this case. Everybody wants to know how to get started. And what we found is there really is no perfect formula. It really is the key. The key is to just let the patients know that you care and get started. Just like you tweaked all those templates for your EHR, and you probably still do, you're going to be tweaking this, as things change with insurance. We know it's an ever evolving system that we have right now. So things are going to change a bit. Along the way, and that's okay. Some things that I took away from all of the offices were really 3 steps. First, observe, figure out, what's going on in your office, what you need, then take the time to gather the information. It's going to take time, but the time up front is going to save you on the back end. So, get together those tools and things, and then finally just go for it. When you have stuff set up and you have, some increased knowledge, just go for it and start having the conversations with the patients. So just some details for the observation phase. One thing I wanted to show you were the topics that came up. You're going to want to look at what topics come up in your own office. It's going to be different for everybody's specialty and their patient population. What we found was across the board, medications came up the most. It was the most common topic that came up for cost of care. So that might be a really good place for you to start. The other thing is start thinking about what you're already talking about now that you know a definition, and also what patients might be saying to you in we call them a trigger. So what triggers they might be saying to you. They might want to talk about it, but they might be nervous about it. They don't want to burden you, and they do want to spend the time talking about their health too. So listen to them and see if you can hear any triggers, like, well, I have to miss work. Do I have to do that right now? Or just saying, wow, yeah, that medication that you gave me last time was expensive. That may be actually them trying to get the conversation to open up. So listen for those triggers, and you don't have to respond to them right then and there. Just start recognizing them. And then see when costs come up now. You probably already do generics. You probably talk about splitting pills to save money there. They probably already ask you about insurance coverage. So maybe those are questions that you can answer, and maybe they're not. The ones that you can answer, then you'll probably want to gather information on them. So when you gather information, you can start so simplistically. I can't tell you how many offices told me that they just Googled. They Googled the price of something or they Googled information. So you can start there. You can also use your EHR. There's formulary information in there, or if you can, have somebody put information in about the cost of, maybe some in-house labs or something, if you can fit it in. Those are some great places to start. ACP and NYACP, we both were part of a different cost of care grants, and we both have resources for you. So I put links in here to our web pages, so you can definitely look there. ACP has an extensive list of tools. We have a shortened list that when we comb through them, but ACP definitely has an extensive list that you can check out. Insurance websites, huge place to start because it's going to be patient specific. So get used to using those. And GoodRx and Needy Meds too. Those were popular because of medications. And I know somebody did ask about GoodRx and Needy Meds, and I in their registration question, I'll definitely get to that. Get to know prices, call places, look at some sites like Fair Health Consumer for procedures, gives you the estimates in your area, America's Pharmacy and FamilyWise. Actually, Dr. Seminara brought those up to me, and they're great to learn the price ranges in the area. Just get to know what's in your area. You don't have to know exact. You don't have to know exact for every patient. Just get to know what kinds of price differences there are between pharmacies and locations. And then make connections and ask questions. So call pharmacists, get to know your billing department. I had one physician who, walked a patient over to the billing department and actually found out, he was like, I can't believe there was actually wrong information in between our EHR and our practice management system that was causing this huge bill. It was like something that you don't even think about. So he got informed by talking to the billing department, and he also said now he knows where to send the patient and who to call to ask questions. So you can definitely create connections within your own organization as well as outside. And then ask staff and patients. They also know. You get to know the strengths of your staff members. That's part of the way that you can introduce this to your staff. Some of them might already have a passion for this and an excitement for it, and you're going to see it right away. And they also a lot of times have things in their head that isn't on paper. And if you get it on paper, you can get it out to the rest of your staff, like what labs are in network, for the Blues or MVP or something like that. And then patients will come back and tell you, yeah, I found, this place is a lot less expensive to go get my Shingrix vaccination. So they come back and share information with you as well. Don't forget to use them as a resource because they're out there experiencing it as well. When you get ready to implement it, we gave you some phrases here, but introduce it to your patients. Hang it up in your exam rooms. This is an example of actually in the waiting room. There's rotating slides. We have those on our resource page, as well as a poster that you can hang up. You can put it in the exam room as well. Just kind of let them know, hey, this is a thing that's going on in our office. There are some phrases at the top. You can be straightforward with patients. Are you able to afford this? Or I think it was actually Dr. Chusing's office who came up with, is there anything we can do to make it easier for you to take care of your health? That's something that lets you open it up in an easier way when you're first implementing this conversation. And your patients. That's the most awesome thing about internal medicine, right? Like you have this relationship with your patients. So you know who you can open up to directly and who you have to who might need a little coaxing to get the information out, so you know how to approach them. So here's some ideas. And then really normalize the topic. Use screening tools. Your front desk can hand out on the sign-in sheet, or not on the sign-in sheet, but on the demographics form. Collect the information there, ask them, make sure you follow up on it if there's somebody who says, yes, I need financial help, but that's one way to normalize it. Another way is when you introduce it, just let patients know it's something that's important to you, so you're asking everybody. I think it not only makes the patients more comfortable, it actually makes the physicians more comfortable as well, because you're screening everybody, or even the staff, if you choose to have your nurses or MAs ask something about medications when you have them room the patient. They know that they're asking everybody, so nobody feels like they're singling anybody out, and nobody feels singled out. So that really helps the comfort level. And then just some workflow tips and ideas. Honestly, the biggest thing that came out of this was the fact it wasn't any like implementation secret. Like I said, there's no secret formula. There's ideas and you can choose what works for you. But the biggest thing that came out of it was really understanding that outcomes that aren't changing, they can actually be affected by cost. So it's just another thing to look at. If something isn't changing with an outcome, yes, you're going to look at other, maybe running other labs or getting other tests, or changing medications, things like that, but also consider something that isn't directly affecting the body. It's their situation. So it could be cost for that. So that, I think, is the biggest thing that came out of these workflows. But there are some tips here that I think will help everybody. Most importantly, do some things on the front end and it will save you time on the back end. I actually think Dr. Lee might be able to speak to this about reducing calls by looking at formulary information up front with the patient before they leave the exam room. Sorry to steal your thunder, Dr. Lee, but I love that. It really does save time on the back end. Dr. Chusing's office actually verifies insurance up front, and the network and being in network, and that really helps. I've had that happen to me personally where there was some confusion on that. So it would have been even better for the office and me as a patient if we had talked about that up front. So, help your patients out there. Not all of them know about this. I was educated and it still happened to me. Also, red flags in your team huddle. If you're PCMH, or even if you're not and you do team huddles, look at the things that aren't getting done. Did a patient not get their labs? Did they not get, their test that you asked them to go get? Maybe they just didn't want to, but maybe they couldn't. Maybe they thought it would be too expensive or they were struggling. So those are some things that you could do before the visit. The front desk, one of the things that came out of this was arm them with knowledge. So a lot of questions they get are billing and basic insurance questions. Have a handout, basic insurance, definitions, like even knowing what a deductible is or co-insurance, out-of-pocket maximum. So have those for them and have a place for them to send the patient, not just a generic billing department, but either a person or a phone number to give them. They can also do the screening that we talked about, and they can also put note concerns in the EHR for you as well. And then for the encounter, one of the things to change is, I think a little thing, but just asking your questions in a different way. Instead of, are you taking your medications? Ask, how often are you taking this specific medication? It might get them to answer in a different way, and you might find out that they're taking it every other day to save money. So instead of just a yes or no, which is really easy to answer and blow on by. Like I said before, just be aware of triggers, and the most valuable thing that people found in the office, besides the formulary that I talked about earlier, GoodRx is on there. That will help them get discounts. It doesn't work with insurance coverage, but it might be actually cheaper than paying with insurance. And if they aren't going to meet their deductible, it might be an option, or for uninsured patients. So definitely look at that, but provide them handouts. It can be anything from, like I said, the basic insurance information to Medicare donut hole. Help them plan for that if you think there's somebody who's going to reach the donut hole or needs to plan for it. $4 generic lists in the area, or just some basics even on preventive care, knowing that it's covered only if you go in network. So those are some basic handouts that we have, and you can also look at ACP as well for their handouts. And then after the visit, close the loop on orders. I know you guys hear this all the time in your different initiatives, PCMH and now it's MACRA, MIPS and all of that good stuff. But actually for this, there's another reason to close it, because if they're not getting something, you might find out that it's really a simple cost conversation, and that could occur in the office. It doesn't have to be afterward, but if you close the loop, you'll start realizing these things. Also look at utilization reports. I think it was actually Dr. Benoit who did this. it was, think about the fact that if somebody's a high utilizer, and I know they're talking about system costs here, but if they're a high utilizer, there's a good chance that they're paying more money as well. And I think some money was actually saved for a patient by switching some medications because they were using, and I forget which office, I'm sorry, but they were using or they were on medications not on their formulary or higher cost medications. So they were coming up on the insurance utilization for system costs, but it actually ended up saving the patient money by looking at those. So there's another way to use those things that you're getting, that information that you're getting. Might not be you doing it, might be staff. So, if you do look at those, that's another thought. And then share at staff meetings. An office that's not on this call actually had staff meetings where they brought the billing department in to say, like, here's an example of an EOB where a patient was charged a much higher amount because of the diagnosis that was used for the Medicare preventive care. So it's just getting educated. So have different departments share at staff meetings and bring it up. See if anybody came across some new cost information that was out there. Did a patient share? Did you find something out? Those are a great place to plan to share, because sometimes we don't think about it in the course of the day, like, oh, hey, I learned this today. So if you plan that in, that would be really helpful. I know we talked about some tools earlier, like Fair Health, GoodRx. Those are online tools. Google is a really good online tool, crazy enough as it is. Insurance websites, huge. But there's other materials and resources. Really, it comes down to people, community, and handouts. Know the people who you can go to help, for help, sometimes even non-medical. Social workers and care coordinators can help you with things for food and housing. And if they can't afford that, they're probably not going to be able to afford their healthcare. Or if they need to make sacrifices to afford their healthcare, we can get them help in other areas, or those social workers and care coordinators can. Your pharmacist, your billing, your IT department, they can help you get the information that you need as well, or make connections with to point them to those people. In the community, you have different facilities that you can call. There's one office who has such a good relationship with their radiology that, radiology in the area, that they'll call to make an appointment, and while the patient's at the front desk, they'll tell them what is going to cost that patient. So if you create these relationships and reach out, you might find out that you can actually get cost information for yourself and or your patients. So I definitely reach out to those areas where you're struggling or want to know the information. And establish those relationships. Another one found free mammograms in their area, and a church that actually provides durable medical equipment. So that was really helpful. They were in a low income area. And then, get patients connected with someone. There's links here for Patient Advocate. It's a national organization. And then the Connected with Someone link is Community Health Advocates, which is based in New York. And, they're free. It's a place where you can send your patients for their insurance questions. How do they understand their plan? How do they pick an insurance? How to deal with surprise bills. So you can send them, you can have resources to send them to there. And there are phone numbers that they can call. And then handouts, GoodRx discount cards, general insurance terms, all the things I talked about before. And, there might be more that come up that you find helpful, but those are the basic ones that we've had. And then I have examples of each of these core values of having out-of-pocket cost conversations. I'm going to leave them in the slide, but I want to get to in the slide deck, but I want to get to the roundtable. So I just want to go over the basics of them here, but really it's stronger relationships both with your patients, because they really are feeling that whole care. That's been a lot of the feedback, is the patients love it. And actually when the patients start loving it, the staff starts loving it even more if they had trouble with the buy-in on it before. And then you also get those community relationships. I've heard a lot of people building better relationships with their labs and their pharmacists around town, and learning things from them, and even their billing department, you heard before. Reducing harm, it's really financial harm. I mean, you've got that, that's the biggest that comes out of the cost of care conversation, but obviously that's going to affect their health and reduce harm there as well, because we're making sure they're getting the right care at the right time. And then knowledge, you're getting knowledge, your staff is getting knowledge, your patients are getting knowledge about their health, about healthcare costs, about what's going on out there. So you're really understanding the system, understanding each other, and building knowledge together. And then, like I talked about before, the outcomes. That was one of the biggest things, is realizing that outcomes can be affected by cost. Not all of them, for sure, not all of them, but there can be effects to that. So that was huge, to have another place to look at what the reason for why outcomes might not be improving, and then helping them to improve. So I do have some quotes and stuff here that you can look through for examples of what these stronger relationships are, and the financial harm and the knowledge and the outcomes. But I want to get to make sure that we get to hearing from the people who are actually doing this. So we'll get to the round table. And before we do that, I do want to just answer some questions that came in from the audience, because I can answer those. I think the first one was already answered. What resources do you provide to your patients? And I'll let, if you guys on the panel want to speak to this when I open it up, you certainly can. But the biggest resources were that I knew about were the handouts that I mentioned here, the donut hole, the basic insurance information, the preventive care, and GoodRx information, as well as $4 generic lists. I think some GoodRx is a big one, and Needy Meds. Other resources were telling them to go through their insurance, as well as giving them the patient advocate phone numbers. And then what role does the GoodRx card or other non-commercial discounts, what roles do they do, or do they have for the patient who is financially stranded? It is their discounts that don't work with insurance. So they can go to GoodRx and see what the cost is at different pharmacies in the area, and they can compare it. They can actually walk in and ask. They should be able to ask the pharmacist to run it with insurance and GoodRx to see which one is cheaper for them. They will have to push a little bit for that, but they can do that. But it might be cheaper, and it might, again, if they're not planning on meeting their deductible, it might be the way to go. So it is another way to look at saving money there. And then training the staff, really, somebody asked about training staff. We'll have questions about that in the round, or question about that in the round table as well. So I'll open that up, but I'll just say some of it was, sitting down in a group and training it. Others were recognizing, talking to your staff and realizing which staff was excited about it, and then, gathering the resources for them. But it's really important just to let everybody know what it is and why they're doing it. And sometimes they're not going to get excited about it until they actually get some patient responses from it. And that came back in every case, that once patients show their positive responses to this, staff just picked up on it and ran with it. So without further ado, let me open up I'm going to unmute the panelists here. So you guys are getting unmuted. I think you are all unmuted here. Yay. Okay, perfect. So everybody's unmuted. So we'll get started with the round table here. The first question I have, I'll ask Dr. Lee first, Dr. Lee from Stony Brook, and then anybody else can join in afterward. How has becoming more aware of cost of care impacted your patterns, whether it be prescribing, referring, decision-making, interviewing, anything like that?
So first of all, Amanda, that was a great presentation.
Thank you.
I am very fortunate to have been a participant in this cost of care project. It's been really educational for not only me, but also my staff and my partners. And I think one of the things, it really has empowered all of us to really be more conscious about what the patients are going through. Paying for meds, paying for their co-pays, especially with, you know, insurance changes. So I think, like you said, helping patients to get their medications at lower cost has been really empowering. And not only that, the patients are so appreciative when they come back and they thank us for helping them navigate this complicated health system. I think that's been really empowering. I forgot what the question was. The question was about tools in our EMR. Hello? So, like I
Sorry, I
said, I
muted
think
myself.
that, oh,
No,
sorry. What was the original question? I
how is
totally forgot.
no worries. How has becoming more aware of costs of care impacted your patterns? So I know you
Oh,
mentioned your EHR, so if you want to talk about that, that'd be great.
well, it's definitely affected our patterns where we refer, which pharmacies we use, which DME companies. We've developed strong relationships with other companies, community resources in our area. But the other thing that has really been a great tool for us, embedded within our EMR, we can actually now see the cost of medication. So um, as a provider, often I'll sit down with my patients and show them the different options for the medications, and we will be more conscious about picking the lowest cost medication. Also, when referring patients out for procedures or for tests, instead of referring them to a hospital-based facility, which often the copay is almost double, I'll refer them to an outpatient facility where there's no associated hospital fee. So just being more conscious of these things, it's really created a stronger relationship with our patients. And also the staff has become more knowledgeable about these efforts as well. So it's been really an educational experience for all of us.
Wonderful. Thank you so much. Does anybody else have anything to share about how their patterns have changed?
This is Donna Simonara. I would just say that my eyes were really opened how I had maybe made some presumptions about about my private practice and assumptions that patients with insurance would be able to cover prescription costs. My EMR is eClinicalWorks, and it does sort of light up for me cheaper options for patients based on their insurance. And so I thought if I stayed within those parameters that would be enough. However, it's not, and my eyes were really opened by that. Also, patients who have very high deductible insurances were really struggling just as much as patients might in my geriatric clinic at Staten Island Hospital, who I knew had no insurance or were also grossly underinsured. So my eyes were really open to the difficulties of the high deductible patients and the patients who, although they had copays, the copays and the variability within those copays sometimes had them choosing to not take certain medications or spreading them out over time. And by pursuing a conversation with them, that's the only way I really learned that, because it wasn't something that they necessarily were bringing up to me. I mean, the occasional rare patient would. I had started out by trying to train my staff to do some of this initial inquiry, but that was not really taking hold. I then made up a poster in the office waiting room that if you had a question about paying for or affording your medications, then ask the doctor. And so people did feel much more comfortable bringing it up to me. And I think that, just as you had pointed out, Amanda, that engagement with staff happened after it was really embraced at the top. That's definitely what happened in my practice as well.
Mm, awesome. Thank you so much. Does Dr. Benoit or Karen, do either of you have anything that you wanted to share?
Yeah, sure. This is Jeremiah. I think our habits and process in the office changed with this project quite a bit. It was very easy to add this question, and what I decided to do was to add it to all my annual physicals as part of the screening questionnaires that we have patients fill out for some of their other requirements. We just asked a simple question: do you have any questions about the cost of your health care? And if they checked yes, it just initiated that conversation in the room. I would just follow that up. And it led to some good discussion. Sometimes it was just general questions and a lot of explanations about healthcare costs and differences in types of payment, like copays and deductibles, and what that meant. And it just allowed us to kind of explore the options and understanding of what the patient was going through. And I think it helped quite a bit.
Awesome. How about Karen? I know, thank you so much for sharing that, Dr. Benoit. Karen, I know that you had some feedback from your patients about how they felt about the cost of care conversations with them. Can you share a little bit about that? Is she on here? Karen, are you unmuted? I don't hear her. Okay, well, can anybody else share how any patients felt about their about having cost of care conversations? I think Dr. Seminary, you already said that they gave really good feedback.
Yeah, they really did, Amanda. I think once it was initiated and they realized that I was interested and that I cared about it, that really helped. Hello?
I'm still here. Yeah, sorry about that.
Okay, I'm sorry. Okay.
I'm sorry. Amanda, can you hear me now?
This is Susan.
Yeah, I can hear you now,
everyone's
Karen.
still
There we go. Okay, we got it.
Okay, I'm sorry. I had to press pound, and I'm sorry that I pressed pound over Dr. Lee there.
No worries, not a problem. Go ahead. What was the feedback that your patients had given to you and Dr. Chusing?
Well, our biggest thing was that we focused on our referral sources, and we found that we had a huge percentage of patients that just, once we sent them to a specialist, that it seemed like they went forever. So it was a great eye-opening experience for my husband, Gordon, that he would talk to the patients about their referral sources and how often they're going. And the patient actually felt really good about saying, "Oh my gosh, you mean that I don't have to go there forever? I didn't know what to expect." So now what Dr. Chusing does is he refers out, gets the consult letter back, and then once the patient comes back for follow-up, they have a clear-cut plan of how often and how long they think that they need to go through these services. So our biggest savings was with urology. It seemed so we were tracking all of our sources. So we had 60% of our opportunities in urology that we could Gordon could take over the care and the medication management, and the patient no longer had to go back to the urologist. So it was really eye-opening, and it's really a good feeling for the patient to know that there's a plan in place for the care going forward and how long it has to be.
Yeah, definitely. That's a great tip there. I like that. And to any of you, what tools and resources have been the most valuable for you, your patients, and even your staff? What have you found to be the most valuable?
Hi, this is Susan Lee. So I think for our practice and for my staff, using GoodRx and the tools that you gave us, for example, the poster and also that little worksheet about donut hole and Medicare and annual wellness and what's covered, that was very useful for us. And in fact, we sort of reformatted a lot of that information to put it into our newsletter that we distribute on a quarterly basis to our patients. So I would say the tools, the worksheet that you gave us, the information that's available on the New York ACP website, which you can download, and then GoodRx was a great tool for us.
Did anybody have any additional tools that they used? Dr. Seminary, I know you had found a few sites.
Sure, thanks. I had been just sort of browsing on Google, and I was working with a patient, and I think I'd shared this with you, Amanda. I was trying to find how to get the cheapest cost for out-of-pocket Atorvastatin. and the patient was taking 20 milligrams a day, very commonly prescribed drug, and I found familywise.org. And on familywise.org, I was able to get a breakdown of prices by zip code, and there was quite a variety that was evident there. So, for instance, at the local CVS, it was $35.99. At the local Walgreens, it was $30.99. At the Rite Aid, it was $22.56, and at Walmart, it was $9. And then I went to americaspharmacy.com, which said that they would do, if a person prepaid, they would be able to save more, but they were starting out at $7.26 for a month's supply, and then they recommended that the patient purchase 40 milligram tablets, cut it in half, and then their monthly costs would be $3.70. So there was a tremendous amount of information that was available just by sort of scrolling around. And of course, these two sites for me, familywise.org and americaspharmacy.com, are ones now that I have sort of on an internal sheet that we made up at the office to just hand out to patients to help them and guide them in some of those out-of-pocket costs. For the conversations that I've had with my patients, the most significant cost has always been the pharmacy costs. I have one or two patients who have very high deductibles, and so for them, some diagnostics were problematic, although in general, the costs for diagnostic studies in my patients who have insurance, I have not gotten feedback that that has been a very big problem for them. For those who had high deductibles, that was, and then we had to start to really, call around and compare, and I think that Dr. Lee had mentioned the utilization of non-hospital resources in that case, and we found that to be true. I did find in my geriatrics clinic at Staten Island University Hospital, which is part of Northwell, that the Vivo pharmacy, which is the Northwell pharmacy, was willing to deal for my geriatric patients in clinic, and they were willing to offer very, very low generic prescriptions for my patients. And I hadn't even thought of reaching out there, and I used the resource of the geriatric pharmacist in the clinic who said, let's give them a call and see if they'll give us a deal. And they did. It never would have occurred to me to have done that before.
Who knew you could snicker in medicine?
Who knew?
I think a lot of times, one of the things that from being involved in this project is just asking people or even yourselves to just ask the question and ask what is the cost, because the patients and we also have the right to know that, and it's not transparent. So I think educating everyone that's their right, because there's so much variability and cloudiness in healthcare these days.
That's very true. Yes, price transparency is becoming a big thing for sure. Dr. Benoit or Karen, did either of you have any tools or resources to add for even your staff, what they found valuable, or you, patients?
Well, this is Jeremiah. Now, our office found the GoodRx was very helpful. We're using that a lot now.
Awesome.
And this is Karen,
Right, well,
and we're a part of CPC Plus, so we have the Medicare feedback performance reports that we utilize for different specialists and medication management, as well as ER and inpatient.
Okay. And thank you guys for sharing the tools. And just in our last 1 or 2 minutes here, I was wondering, just to answer the training question about how to train the staff, what did Dr. Seminara, you mentioned doing it from, getting buy-in from the top down. What else did any of you do to introduce this to your staff?
So this is Susan Lee. So one of the ways that we introduced this project is that I sort of selected some champions for the project and introduced them to some of the tools, and also to get them familiar about different concepts and costs of care. And then from there, we sort of made it like a workflow to ask the questions if any patients were having any financial difficulty. And then what we did was we made the tools available at each nursing station and trained the staff on how to look stuff up and give out handouts. So it really wasn't a lot of training involved, but once the staff were empowered to do this, the word sort of spread, and it's just become part of our workflow. So I would say any office that wants to make this part of their workflow, it's not a big initiative to get started, and it's a good thing.
Thank you. And Karen, I know you are involved in a lot of initiatives. Was this similar or to other initiatives you've done? How did you go about introducing this to your staff and the doctor?
We do have many initiatives. So we have a section in our monthly meetings, which we're a small office, so we have 7 additional employees only, so it's really easy to implement things into our workflow. So we have a section in our monthly meetings that are just for new project items, and this was one of them, and it really took off, and the patients really appreciate it and thank, so the employees like it even more because they're getting recognized that they are helping the patient in a way that you wouldn't think in a medical office it's going to happen, that I'm going to save you money. So they're really into it. They like this one the best so far.
That's awesome. That's amazing. That's a great way to end. They like it the best so far. I think we're at the end of our time, and I know everybody needs to get back to their patients. And I thank you so much. The information you shared here was so valuable. And I have to say personally, it was amazing working with every single one of you. I learned a lot, and I feel like everybody's going to learn so much from you. So thank you so much for joining us today. If anybody has any follow-up questions in the audience, please feel free to reach out to NYACP. If you have any questions about training or the resources, reach out to me, Amanda. You can give us a call. It's on the website. My email's on the website, and I'd be happy to answer any of them for you. But I am going to let everybody get back to practicing, and thank you so much. I appreciate it. Have a great day.
Thank you, Amanda.
Bye.
Thanks, Amanda. Bye.
Bye-bye. Bye.
Bye-bye.
Bye.